I apologize that yesterday the book that I present was a book related to lunar man, but this is due to the fact that the book was related to experience of 200 years ago. Then now we have to discuss just about lunar woman. I am quite sure, particularly in medicine. By the way, we have to discuss about how it's possible to change the ability to support the patient after surgical procedure. We are quite sure that we need some exercise, but we need something more to perform exercise in the right way, not just using the manual approach that typically rehabilitation process tried to use in the last years. And I would like to focus the first part of presentation about neuromodulation. Neuromodulation after surgical procedure may be very, very important. In this moment, we have three possibilities to perform neuromodulation. The first one is related to TDCS. We know that TDCS is important. It's possible to increase all the knowledge about what happens when we perform TDCS, but TDCS is a very important system to perform neuromodulation. Another one is to use electrical stimulation to perform transcutaneous epidural spinal cord stimulation. I will show you something. And the final one is auricular vagus, transcutaneous auricular vagus nerve stimulation. First of all, direct current stimulation. We know that it's possible to perform this kind of neuromodulation. We don't know exactly in this moment the best patient to do this and how to do this in the right way, but in any case, in the near future, we have to work a lot about neuromodulation using TDCS. But yesterday, when we discussed about what happens when you cut a tendon, or you perform elongation, or you reverse the tendon position, means that you change a lot of information to the spinal cord. And in the spinal cord, we have a lot of traffic to perform activities related to the rhythmic movement of the lower limb or interlimb coordination and activities of all the muscle involved in this one. And to perform modulation, we have to try to modulate interneurons. Interneurons, spinal interneurons, are gatekeepers of neuroplasticity and recovery of function. And it's possible to do this transcutaneously, non-invasive, at lumbar level and at cervical level too. And obviously, it's possible to perform this using some implantation of stimulator. In the audience, there is Stefano Carda that collaborates with the group in Lausanne that implant spinal cord injury patient, but Paul Winston is very close to Andrei Krasikov in Vancouver, and very recently I met Andrei in our center, and we discussed about all the possibilities of transcutaneous epidural spinal cord nerve stimulation. It's very important not only in spinal cord injury, but it's very important in upper motor neuron syndrome. And very recently, this group demonstrated that you are able to enhance walking performance and reduce spasticity too. Then maybe that using transcutaneous spinal cord stimulation before surgical procedure is possible to have some information to try to predict some results after surgical procedure. Again, we have some studies related to what happens when you perform this one after stroke for lower limb control, and we have demonstration that it's possible to change lower limb control. This is from Chicago, and again, we are moving from transcutaneous spinal cord stimulation to vagus nerve stimulation. This is very important because vagus nerve stimulation is another possibility that we have to perform neuromodulation using implantation of the system, and the group in Houston of Gerald Francisco demonstrate that it's possible to improve the upper limb function in stroke patient using implantation of vagus nerve stimulation, but it's possible to perform non-invasively at transcutaneous auricular vagus nerve stimulation, and is a stimulation of the afferent part of the vagus. Then this is a key point to target plasticity of the system after surgical procedure, because you don't have any problem related to seizure of the patient and so on, and it's possible to perform it at home too. Then is a possibility to maintain a continuum of care, not only using implantation, but using something related to transcutaneous non-invasive stimulation. Then we move from neuromodulation to a lot of different possibilities for the upper limb of robotic system to perform training. We know end effector, exo. We know that we have a lot of different systems to do this. But again, it's possible to have a combination of robotic training and neuromodulation, particularly using transcutaneous auricular vagus nerve stimulation and transcutaneous epidural spinal cord stimulation. This is November 25. This is a paper, last minute paper, able to demonstrate this from New York. This is a very important possibility to support our patients. Again, about upper limb robotic system, we are moving from mono to bilateral coordinate movement of the upper limb using the master-slave system that we have now, using different software to control the upper limb. And we will have a lot of possibility to increase coordination, interlimb coordination, bimanual task. Then we have the possibility to change the experience to control the upper limb of our patient. And virtual reality in combination with robotic training may be another way to change completely the future of rehabilitation of our patient. This is very, very important. This one is a very nice system from France, from Saint-Étienne, focus on mirror therapy, and particularly for the upper limb, when we perform surgical procedure that change deformity of the upper limb, it's possible to change motor imagery, motor control, and the perception of the patient of control the system that we have using a very nice system focused on mirror therapy. Then we move to the lower limb. Lower limb change after surgical procedure, obviously in terms of motor control, but particularly change in terms of proprioception, skin information, sensation, and perception of the patient to control the system. We have the typical locomote robotic training on treadmill, but the future will be to move using different exoskeleton on overground gait training, because during overground gait training, visual information, vestibular information, and so on, and trunk control too are completely different. This is the exobionic system, but the future is the future, but we have the possibility to do this now, is to use different robotic system depending on the condition of the patient and depending when we start the training with the patient. Using the exobionic system, it's possible to support patients without any possibility to stay in standing position. This is from Paris to Atlante Wondercraft. It's a very nice system because it's the first one able to support the patient without any need to use crutches or walker or quadruped and so on. Then change the overground training of our patient to restore gait control, or you have to move to system able to collaborate with the patient when the patient is able to maintain standing position. This is the typical Cyberdyne, but now we are moving progressively to soft robotics. This is the MyoSuite. MyoSuite is a very nice system, low-cost system, able to change the control of the hip and of the knee, maintaining the stability of the patient in standing position because perform hip and knee extension. Then may be very important to support patient after surgical procedure to be able to maintain standing position during stance phase in the right way, in the best way, and to increase by this way the control of the trunk. One of the key points is this is a low-cost system and is a possibility to perform long-term care at home too. This is another key point until when we follow a patient after surgical procedure. Another robotic system at Alberto Eskenazi demonstrate that is able to support stroke patient is Rewalk Restore that is just monolateral and particularly focus on distal part of the lower limb. Then we have dermoskeleton. This is Kyogo from Canada. This is another robotic system able to support the knee, just the knee. Knee flexion extension means using a system like this one, you have the possibility to facilitate the control of the flexion of the knee during swing and to facilitate the reaction of the knee in extension during stance. Finally, the new generation of robotic system may be related to the robotic system able to support the control of the hip. Hip flex extension is very important. This is the Onda walking assistive device. And using a system like this one or similar like this one, you have a lot of possibility to change the motor control, not only of the hip, but of the knee and the trunk too. Then you have a different possibility to use different technologies for the lower limb, depending on the condition of the patient. And if you don't have the ability to maintain standing position, this is a new one system from Switzerland, able to perform a lot of different exercises in supine position using different inclination of the trunk and using different support, robotic support of the lower limb. And particularly, it's possible to use a master slave approach in this one too, because the physiotherapist maybe that try to perform the movement and the system will do exactly how the physiotherapist would like to perform the movement. Balance control. Balance control is another key point. We have new robotic system to perform balance control in sitting position or in standing position, and it's possible to combine this one with other robotic training or to prepare the patient to use robotic training in standing position using system like EXO or some robotic system. At the end of the story, we need now to increase our ability to combine a lot of different technologies, able to work together to collaborate with the patient, and we are moving progressively from robotic to cobots, collaborative robots. Collaborative robots during neuromodulation may be the future, and virtual reality too will be the future related to this one, but particularly, we have to change the vision of the future that we have to face with our patient. Then, more precise surgical procedure, new surgical procedure, but in the same time, new strategies in terms of rehabilitation to increase the ability to reach the best goal for our patient. Thank you very much for our attention.
Thank you, Franco. Do you know, I don't know if you know, but he turned down the role for the new Daniel Craig James Bond movie. Are there any questions for him while he's here? Do you have a preferred system that you use with your patients?
No, we have a lot of different systems and we try to personalize the robotic device and the fine-tuning of the robotic device to the patient. Because to use a lot of different technologies means that you are able to personalize the patient, do the treatment of the patient.
And are most of them used for rehabilitation, or do patients also rent or buy them?
Please?
Do they use them at your center at Villa Beretta, or do they take them home with rental?
In this moment, we use particularly inside the rehabilitation hospital, but particularly when you look soft robotics possibilities, I think that the near future and the next year will be the year to start to use soft robotic system or something related just to the hip or just to the knee at home too.
Franco, thank you for that presentation. It was terrific. I wonder if you could give us a little bit of an insight from your point of view. You talked about all these different single joint devices. You have a device for the ankle, a device for the knee, a device for the hip. How do you figure out which is the way to go? You talk about personalization, and I understand that, but that's too general. I wonder if you have a feeling or a sense of how you choose which joint to address first.
Okay, excellent point, Alberto. First of all, if I have major problem in terms of trunk control, I think that we have to try to use Locomat or exobionic system. Again, depending on the pattern that you have during gait, stiff knee, for example, I think that we try to use or something able to change the control of the hip, because we realize that if you change hip flexion in the right way during swing stance, you are able to change the pattern of the stiff knee. And sometimes we use, when we have stiff knee, Kyogo, because Kyogo is able to change the ability to control flexion. In the same time, just during the last months, we realized that if you use transcutaneous spinal cord, epidural spinal cord stimulation during robotic training, you are able to modulate the activities of the patient during gait. And this is exactly the same for the upper limb too, because it's very important for the upper limb too.
Thank you, Franco. Thierry Del Tomo, the phone. Did you try epidural stimulation in stroke patient? Because the study is related to MS patient, which who usually are bilateral. Did you test it in stroke?
Yes. Yes, we start in the last 3 months to use it in stroke patient, and we will have the possibility to have a trial in 2022 to check the change of pattern of the upper and lower limb, and particularly for the lower limb during cycling, with and without the transcutaneous epidural stimulation. And please, Paul Whiston, try to contact Andrei Krasyukov. Andrei is a very important expert about spinal cord injury treatment, but you will have the possibility to have a lot of information and to translate information from spinal cord injury patient to stroke patient.
Bonjour, merci beaucoup. Une question, quel est votre modèle de financement?
So he's asking a question about financial.
Yes, I realize, because I understand French. It's important. I speak English so and so, but I understand French. From a financial point of view, we have obviously a research project with financial support from foundation or the government or European project too. But in the same time, we are using this kind of new technologies during regular activities that we perform under the umbrella of the national healthcare system. We are a non-profit organization, then it's possible for us to do this.
Franco, hi. This is Philippe Régoire from Poitiers. Thank you very much. That was a very exciting presentation. Franco, I was wondering, I'm using a spinal cord stimulation for pain for my patients. And I had the opportunity to work with Grégoire Courtine from Polytechnique School from Lausanne to try to design a study together. There is something I don't understand. You are talking about transcutaneous epidural spinal cord stimulation. So for me, epidural stimulation is something you put in the canal next to the spinal cord, and transcutaneous is something you put through the skin. So what kind of device exactly do you use for this procedure, please?
No, I realize perfectly that generally speaking, epidural stimulation is inside the canal, but this transcutaneously means that you put the electrode at lumbar level or at cervical level too. Then you have to use 1 millisecond duration, and you are able to change the intensity of stimulation, moving progressively depending on the patient to 50 milliamperes. It's possible to do this. And you have to think that in Seattle too, there is a trial to use it, non-invasive, transcutaneous epidural stimulation in spinal cord injury to improve upper limb control of the upper limb after spinal cord. Then is a way to move progressively from the skin to inside the epidural space.
And Franco, you know, with the spinal cord stimulation, I mean, implanted for to restore the motricity of the lower limbs, what's very difficult for us is not only to create and restore motricity, but also to synchronize the pattern of locomotion with, I mean, the ability to walk, and it needs very complex programming stuff with actually the Medtronic device, but with very, very special programs and 16 contact leads, very complex electrical fields. So how can you reproduce that with an external device, and how many contacts do you use? What kind of device exactly do you use?
Excellent question, this one. When you are looking implanted system, we have some experience about this. Obviously, you have to manage all the possibilities that you have to stimulate using different electrodes. But why? Because you would like to produce the pattern of the lower limb. This kind of transcutaneous epidural stimulation is something to create a different global fine-tuning. You don't have exactly a relationship with stance and swing or all the activities of the lower limb. In some ways, like TDCS, that don't perform exactly the stimulation of the specific pattern, is a facilitation to restore the control.
Thank you very much.
Then you perform continuously and during different phases of the gait, for example, or during different activities of the upper limb.
Okay, thank you so much. Is there any more questions? All right, thank you so much, Franco.
Bye.